everyone. My topic for today's presentation is evidence-based intervention for brachial plexus injuries. Alright, let's talk about some facts and figures. A recent study by Backby et al. Showed us that the incidence of brachial plexus injury ranges from about 0.15 to 0.3%. That is, about 3% of the kids, or 3 out of 100, are diagnosed with brachial plexus injury. The spontaneous recovery rate out of these is about 84%, which would mean that about 16% would still require surgical intervention. The study also showed us that permanent injury occurs in 0.5 in every 1,000 child. Examination. For every intervention, I believe that a thorough examination and evaluation is extremely important. So I'm going to briefly discuss the examination. The first thing we need to check is the range of motion. It really depends on when the child comes to us for intervention. For the first few days after the injury, most of the times the arm is very flail and has no tone in it. But if the child comes very later in life, he could probably have developed some amount of tightness because of overuse of a particular group of muscle or disuse of some muscles. Muscle strength and function. Sensation. This is a very important part that many a times we miss. It's because it's difficult to find out how to do the sensation, how to do an evaluation of sensation. But it is a very important part of the examination when it comes to brachial plexus injuries. Activity and participation restrictions. All these together form an examination. Range of motion. Upper extremity and cervical range of motion. I have seen a lot of times therapists tend to forget that we need to check even the cervical range of motion. In this case, I would divide the evaluation in two parts. One is for infants, or in acute case, and in chronic cases. In infants, passive range of motion should be examined with extreme caution, because most of the times, as I mentioned, they have no tone, and there's a large possibility of shoulder getting dislocated. Note for the tone in every movement of the muscle, of the joint, In children 2 years and above, I would say 2 years and above is because they start understanding simple commands, and in other cases when it's chronic. We have to check active and passive ranges of motion. That is because by this stage, if there is no treatment given, or if they have not given adequate amount of treatment, or in cases where they have extensive injuries, we may find some amount of tightness already developing in these children. Alright, motor strength. It's a challenge to find out the exact motor strength in infants. I wish infants would just lift their hand up when they're sad, or just go off to sleep when they are asked to, but they do not. They have their own rhythm going on. So one of the best ways to observe, or I would say document, is observe the quality of movement. Another way to check how strong a muscle is to compare. Since brachial plexus injuries are more commonly occur on one side, what we could do is check for reflexes such as neck righting reflexes, Moro's and Gallant's, and what we can do is compare the two of them to see how the quality of movement is on each side, and then give an idea of the grade of strength they have. phrenic nerve is involved. I wouldn't say very commonly, but it is involved in some cases with associated with brachial plexus injuries. It's very important that we do not ignore that part. So to check whether the phrenic nerve is involved or not, the best way to do is check the symmetry of abdominal and thoracic muscle activities. In the book Physical Therapy for Children, I found out this muscle grading system that we can use for infants. Very similar to our MMT, but it is more about observing the motion in case of these infants. So, right here on the right hand side is the scale. In cases where children understand simple commands, we can use our MMT, which would make life relatively easy. But what makes it more difficult is children tend to compensate, use trick movements much more than adults. So we should always keep an eye for them. And again here, I would suggest always observe the quality of movement. That's our usual manual muscle grading grades, just for our reference. Checking the sensation is always going to be a challenge, and I feel it is more of a challenge when it comes to infants, as they cannot verbalize their findings. What makes it all the more difficult is studies say that sensation testing in cases of infants is not a very reliable test. Narcas in 1987 came up with a grading system where he divided the sensation into 4 categories. S0 would be that the infant is not reacting even to a painful stimuli. S1, the child showed reaction to pain. S2 was he showed reaction to touch. And S3, as it mentions, apparently normal. Another thing that we should always keep in our mind is that the sensory involvement may not always be equal to the motor involvement. It may either be more extensive or it may be less. In cases of children above the age of 2, or I would say who are cognitively big enough to understand simple commands, we can use our normal sensory techniques, use a sensory chart, mark it down, and we also need to understand that it may take up to 2 years for the sensation to come back to normal. Often hypersensitivity appears in the course of recovery. That is a good sign. It means that the nerves are regenerating. Parental education. I have put that in caps lock is because we need to inform the parents that along with the motor problems that a child comes with, there are a lot of sensory troubles a child may have, and thus it's important for them to know that they may not be able to judge temperature that well. So when they're taking a bath, it's a very important thing. Along with that, it would also affect the climatic changes would also affect these kids. Activity and participation restriction. Again, when it comes to infants, it's more about tracking their developmental milestones because that is what they do. That is the activity to do. That is how they are going to participate in the adult world. A lot of times, infants show either delay or they even may skip the milestone completely. Many infants also develop compensatory techniques, like with right-sided brachial palsy, they may not roll to one side. They would rather roll to the other side, which is easier. or creep with one arm. Trust me, I have seen kids doing that. That doesn't stop them from moving forward or moving even slower. They are pretty fast. When it comes to children above the age of 2, our scope of activity and participation expands because by this time they are more vocal, they have started going out, interacting more in the social environment. Um, it is seen that the activity limitation and the participation restriction are like indirectly proportional to recovery. What this means is the more the recovery, the less the limitations. The lesser the recovery, the more the limitations. Activities such as fine motor skills, overhead activities, shoulder external rotation, that will be combing your hair, buckling your hair, um, raising your hand up, um, lifting something using your biceps, so lifting things using supination, are most often the ones that are restricted. These activity limitations lead to a number of participation restrictions. It can be in the educational as well as in the sports or extracurricular accomplishments. CAPE and PAC are two useful tools that can be used to judge the activity and participation restrictions. Treatment. The treatment for brachial plexus injury is divided into two sections. One is the conservative section, the other is the surgical one. Conservative treatment is followed for the first 3 months of the child's life, almost always. Physical therapy plays a very important role in the conservative management of brachial plexus injury. The treatment as a physical therapist is divided into 5 different sections: active movements, weight bearing activities, assisting in developmental milestones, bimanual tasks, and sensory re education. When it comes to active movements, we should always start with active assisted movements because for the first few weeks after the injury, a lot of muscles are in a hypotonic stage. So they are not only weak, they have loose tone, and that makes it very easy for the joints to be very unstable, and shoulder dislocations are pretty common. So we should always start with full range active assisted movement so that we know what how much of a child can move, and since it is assisted, we can make sure it goes through all the entire range of motion without damaging or hurting the joint anymore, especially the shoulder. As time goes, we move from active assisted to active movements, and our goal is to make sure and encourage overhead reach outs after they start gaining strength in their arm. Weight bearing. Weight bearing is pretty, I would say it is very debated in the world of PTs. We should always proceed with caution. Again, the reason being that the joints are pretty, they do not have a lot of support system around them, which would cause subluxations and dislocations to happen very often. We should always start with proximal weight bearing, and with proximal, I would say from the trunk. So start with the scapula, move, do a lot of weight bearing at the scapula before we move on to the shoulder. And the progression is very slow. It depends on every child. It also depends on the therapist who's working with the child, but we should always make sure that we do not cause any damage. Even if the progress is slower, it is alright, but the quickening up the weight bearing and pushing the child and leading to more damage is what we do not want to do. Developmental milestones. I put that in is because a lot of children have trouble clearing their hand while rolling, or they do not, they many times skip milestones like creeping and crawling. just because they do not use the arm that is affected. And as therapists, it is our duty to make sure that we assist them in the developmental milestones as much as we can. And I use a lot of motor control uh, theories, I would say. The more of repetitions, the more practice the child does, the better they get with their rolling techniques, their hand clearance technique, and the creeping crawling too. Bimanual tasks. This is a very important developmental milestone that the child is, I wouldn't say deprived of, but it is more difficult than if the arm was not affected. Two major difficulties is getting the strength to go against gravity so that they can come up to midline to reach out. Only when they come up to midline they can have bimanual task, switching from one to the hand to the other, a lot of hand to hand, a lot of hand to feet, and these are all sensory and fine motor developmental milestones that are very important according to me. And last but not the least, sensory education. Um, Kids can be either hypersensitive or they could be hypersensitive. So we should always examine the child very carefully before we start giving any amount of tactile, proprioceptive, or temperature awareness techniques. And when it comes to sensory education, the parents should be well informed about it. Surgical cases. If no amount of active movement is seen in the child's arm, or a lot of surgeons like to refer on the biceps activity or the shoulder external rotation activity. If they see that there is no improvement, further evaluations are done, and a team approach is taken, and surgery is decided. When it comes to surgical cases, our role as physical therapists can be divided into three sections: preoperative care, immediately post-operative care, and post-operative rehab. Preoperative care. We have to make sure that the muscle activity, we have to maintain the muscle activity, joint protection, and electrical stimulation. When it comes to maintaining the muscle activity, strength training and maintaining the active movement as much as we can is very important, because the stronger the muscle is before they get into surgery, the recovery will be faster. Joint protection. Sling is used a lot in cases of adults. I haven't, there was no relevance I found when it comes to pediatrics. But I did want to mention this because a lot of kids do have extremely weak shoulders, or uh, they have they have a high recurrence rate of shoulder dislocations or shoulder um, subluxations. And in those cases, joint protection techniques are very important. So, if need be, we may even need to immobilize the arm whenever we are not working or not strengthening it. And the principle of trying to avoid any amount of overwork. Electrical stimulation is again a very debated part of modality when it comes to children. Um, it really depends on the kid, on the parents, on the clinical judgment of the therapist and the surgeon and the physician. They play a very important role in deciding how much should we go ahead with electrical stimulation before any operative surgery is performed. But it is very commonly used in adults. Immediately post-operative treatment can be divided into three sections as part of physical therapy management. First is time for healing, movement, and pain management. The time for healing, I would be in very constant contact with the surgeon or the physician who's performed the surgery on the child, is because he has seen the extent of damage, the amount of work that the child needed at the nerve or the muscle level. And I would respect the need for time for the child to heal. But in this process, we also, as physical therapists, need to make sure that we do not lose the movement. And thus, after the appropriate time required for healing, we should always progress slowly. So, start with passive range of motion and then start activities in the gravity eliminated plane. So, make sure that the muscle is started to be worked on, but one baby step at a time. Pain management. Very difficult in case of infants because very difficult to judge if they're in any cases of pain, if they are in any pain, any amount of pain, what causes them the pain, or it is just a discomfort. If need be, we may require medical and pharmacological interventions. Post-operative treatment. The majority of uh, this is where the majority of rehabilitation takes place, and I can divide the post-operative care into three major segments: strengthening, movement, and sensory re-education. By the time we are into the phase of post-operative rehab care, uh, it's time for the muscles to start strengthening. So we can start using anti-gravity. We can start using some weights depending on the age of the child. The other way to start do a lot of resistive training would be weight bearing. Also, we can do electrical stimulations are used a lot to in cases of especially in cases of nerve recoveries or post nerve grafts or post tendon transfers so as to re-educate the muscle and the nerve about how it's more of a motor planning that the more you give the electrical stimulation, the more the muscle works, the more the motor planning is engraved in the muscle and it becomes a part of their normal activity. Also, as a part of active rehabilitation, I would use a lot of reach outs and PNF techniques, but in all this, we need to make sure that therapy is always includes some amount of play for every child. Movement. Depending on the type of surgery, uh, slow progression is advocated to full range of motion, but we need to make sure that within a good period of time, the child reaches the full range of movement possible. Another thing that could be restricting the movement is the scar. And scar mobilization can be done using ultrasound or manual techniques. This is highly subjective because it would really depend on the age of the child and the amount of scar tissue that the child has depending on the surgery. Sensory re-education. Regular inspection is a very important part of sensory re-education. Along with the sensory inputs that we give to the child and make sure it is followed as a regular regime at home, we need to also keep this in the back of our minds that it may take up to 2 years for the child to get his sensory uh, sorry sensory input back into place. We've learned about the SMART goals all our physical therapy life, I would say. So it is really important to make sure that the goals, even in case of pediatrics, are SMART. They have to be measurable, they have to be simple. But there's another important component that I would like to include is the developmental part. We need to make sure that along with the goals being SMART, they should also be, especially in case of these infants, they also have to relate to their developmental progress. Adjunct therapies. I have put the adjunct therapies like CIMT into a different slide altogether is because we can use this at any time of the treatment procedure, be it conservative or be it post-surgical. CIMT, also known as the constrained induced movement therapy, has a lot of evidence to support its effectiveness. There was one study that showed improvement in grasping, lifting, reaching, as well as carrying activities. Another study that I saw also compared low dosage, that was 3 hours a day of CIMT versus 6 hours a day of CIMT, and both showed improvements and almost equal amount of improvement. Modified CIMT was a study, as you can refer the article that is mentioned in the bibliography later. What they did was they modified the technique, and they also divided the CIMT into two parts, one wherein they used the affected arm only for activities, and the other part, the other half of the treatment, included bimanual activities. And it is showing to be a very promising approach for CIMT. I personally am a fan of constraint induced movement therapy, but I do understand that it has its own restrictions. A lot of cultures, a lot of beliefs it do not agree with the approach. And where I come from, we back in India, a lot of times when CIMT was mentioned, uh, a lot of surgeons, a lot of physicians, um, what they like to do was plaster or put the non-affected arm in a cast for about 4 to 6 weeks, so that there is no use of the arm. I do not personally agree with such strong constrained induced movement therapy, but there have been a lot of changes in the approach of CIMT, like using of mitts, or as you can see in the picture, just tuck the arm inside the shirt so that the child uses the affected arm. So, modified constraint induced movement therapy was a very promising approach for me. Aquatic therapy. Um, I am personally very biased towards aquatic therapy. I have been working as aquatic therapist for about 6 months, and I have seen a lot of use of aquatic therapy. Again, I put this into adjunct therapies is because we can use it as a conservative management, or you can even use it for surgical management. Water, it's an excellent source of, it's an excellent tool. We can use it for resistance, assistance, we can use it for a lot of different purposes, including fun. The use of warm water, where I was lucky enough to be working in a community pool where they maintain the temperature about 90 degrees. So it was a pain reducing agent too, and it helps in case of infants, is because it's difficult to pinpoint where it hurts or does it even hurt. So it is a natural medium wherein we are working, getting our activities done, but pain reducing is like icing on the cake. The buoyancy of water. A lot of weight bearing activities become much easier in waters because the buoyancy does not put that much impact on the joints, and thus we can use weight bearing techniques, push the child into resistance without causing any damage or having any um, harm on the joints. These are the articles I referred to. Please let me know if you have any more questions. Thank you. Thank you for a very patient here.